About the ages, age 4 to 7, it's all about skeletal age, so that may not be the right time, but we'll just try to do it. So the best time to start for kids is going to be when a little bit before they lose their first tooth. So that's the best time right there. You can start with the habit corrector earlier, but in terms of moving on to our kids' appliances. So kids' appliances, and don't worry about all this alphabet soup. I see there's C's, there's IGs, there's G's, don't worry about it. Will help you with finding the right appliance that you need, and you don't have to memorize any of this. But the different appliances are characterized by whether or not the 6s or the permanent first molars have erupted yet. So it's just a size thing. You'll also see a variety of different shapes. There's some that are open, there's some that are closed. It's mostly just for getting used to it, ease of use, and potential aspiration. But that's the differences that you'll see there. Okay. Now, before we get started with all the components of the different appliances, we're going to go and actually skip to this slide right here. So we're going to talk about, and introduce for some of you, EG. So I had actually never ever heard of EG. It's eruptive guidance. People call it all different things, guided eruption, eruptive guidance. Basically, same thing. As an orthodontist, this blew my mind. And I'm going to tell you, I'm going to blow your mind today with this. So what's going to happen is it's completely different. So traditional orthodontics, teeth are erupted, braces or aligners move, permanent teeth. Teeth are already crooked or raised, then we go ahead and correct it, right? Teeth are permanent, they're in, their PDLs are formed. We call it collagenous fibers here at Healthy Start, pretty much same thing. But what happens, and I didn't know this, and we all took histology and dental histology and all that, is that it's very, very different. A tooth that's just erupting, if you take a cross section of the tooth, versus a tooth that's fully up and in occlusion. The PDLs are collagenous fibers, they present different. So as a tooth initially first starts erupting, it's coming through like this on the right side right there. That tooth is coming up, right? Its collagenous fibers are not mature yet. Therefore, the function of EG or GE is that if you direct that tooth to come up straight to begin with, that means you put it in the right spot to begin with, not have it go into the wrong spot and then move it. Its fibers were, you know they're elastic, you know those elastic fibers. You know that if you have a tooth and you move it in adult and it relapses, it just has like a little elastic modulus laxity to it and it's going to bounce back, right? It has memory. Well, if you direct it into the right space to begin with, it's going to stay in the right space. That means, conceivably, if you have a great Healthy Start candidate and you help use EG to get their teeth in straight to begin with, your patient, unless they have there's a couple exceptions here, will not need retention past age 12. That means after age 12, they can discontinue their appliances. They can go to college without retainers. They have perfectly straight teeth. All their friends will say, you know, gosh, you didn't have braces? No, you didn't. This is not braces. It's using eruptive guidance therapy to straighten the teeth. Their teeth came up straight to begin with. You take a huge cost factor and eliminate that for the patient or your kids or any of your friends' kids. It's fantastic. So with that in mind, let's go ahead and go back to the components of the C series, okay? So C series is, if they're younger, that means they do not have their 6s in yet. So it's very, very comfortable. It has an open appliance to help them breathe a little bit and get used to it and to prevent aspiration. It's basically gonna just guide the teeth up until their permanent 6s come in. Then you're gonna switch it to another one. Help the teeth guide in straight to begin with. Now, people are thinking, oh, do I have to take an impression for this? Gosh, it sounds like a hassle. Do I have to take a scan? Not necessarily. Eventually, it's always good to go ahead and to get the right fit to take impressions, but initially, you don't have to take an impression of this. We can just size it. And we'll go over all that later with diagnostics. So it's not custom, it's custom fitted in that we'll find the right size for the patient. But our lab already has a variety of different sizes to fit every tooth size. They can go ahead and predict exactly what appliances they're going to need to do the EG to get the teeth in correctly. So I think that's fantastic because trying to take an impression on a 4-year-old or a 5-year-old is not something you want to do. Maybe some, yeah. I took it on my daughter. She was 7 and she barfed all over me, and I'm a fantastic impression taker. So I was like, oh. So not fun. Okay, so who can we use these for? So remember, this is the next step. From habit appliances, pretty much for everyone we talked about, except for those open bites, skeletal open bites, and pretty much. But as we start moving down, we start getting a little older with our patients. It's a little bit more restrictive. But I think this is so cool. Look at the first line right here. Crowding, in the wall again, crowding for any severity, basically less than 13 millimeters. 13 millimeters is an incredible amount of crowding. That's 2 buys right there. That's pretty much, basically they're saying, for any patient, you know, at this stage. Now as we start moving and we go through today and tomorrow, you'll start to see it get more restrictive. So the key is early treatment. Overbite. Okay, so let's talk about overbite. Now remember, when you're screening patients, their version of what overbite is not our version of what overbite. Overbite is deep bite, and you have to explain that to patient. I actually don't even call it overbite because they're just going to hear, they're going to think overjet when you say overbite. I say deep bite and overjet, but that's just me. Here, overbite is overbite. Any overbite, okay? Any overjet. That's awesome. Rotations, especially I think even less so of premolars, but in general rotations of less than 90 degrees, so quarter of the way around. Pretty much any TMJ, TMD dysfunction except for closed lock, and we talked about closed lock earlier. Maxillary spacing, fine, no problem. Open bites, no problem unless it's skeletal, okay, for most part, if it's habit related. Gummy smells fine, as long as that we have an overbite, because when you're going to have to intrude, it's going to be mostly absolute intrusion, some relative extrusion. Crossbite, fine, no problem. And of course, our friend, sleep disordered breathing. So when you start it, we talked about best time to do it is just when their teeth are getting wiggly and the tooth, maybe the first tooth falls out. So if you see some good candidates, maybe they're not ready to commit when they're younger, maybe they don't have sleep disordered breathing, shoot, you can use Healthy Start just for ortho stuff. I mean, you really could. And there's people that do that. It's a braces alternative. It's a healthy, all-natural braces alternative. You just wear it at night. That's incredible, just at night. And everyone that comes into my office or came into my office when I was an ortho, what did everyone ask for first visit? Hey, what are you here for? Here for a retainer. Okay, great, retainer doesn't do anything. But in this case, you can say, sure, we have a retainer. What else are you here for? Invisalign. Okay. So, and can I just wear this at night? Yes, yes, and yes. That's the answer for this. Yes, you can. And there's 50 years of research going back. Now I want to address something real quick. As we move forward, you're going to see a bunch of research and statistics and stuff. Healthy Start has gone through a few rebrandings, real different names, different versions. I kind of call this version 4.0. So Healthy Start is version 4.0. It's had a few name changes. Some of you here have been in version 1.0. So Ortho, Night Guide, etc., Perfect Start. So they're slightly different. As it starts to do something new and more amazing, then we rebrand it and call it something else, just so we can keep it different. So that's what that's all about, if you see that. So best time to start when the teeth become wiggly. If you have a good candidate, or if you just want to start introducing it, you can become the Miss Cleo, the crystal ball of all things ortho, and I became very good at that. I can see a 2-year-old across the room. I can go to a party and see all the little kids and tell you who's going to need braces. And I have no problem going up to parents and telling them who's going to need braces. Oh, isn't little Sally really cute? Oh, by the way, she's going to need braces because she's going to be super crowded. What are you talking about? Her teeth are perfect. Yeah, she's going to need braces because her teeth are perfect right now. And you can say it in a nice way and in a loving way. But you're the doctor and you can say, hey, by the way, here's my card. And they'll think you're crazy. But as soon as the first tooth comes in, guess what's going to happen? You're going to be the first one to call. Well, all right, no worries. As soon as that first tooth comes out and the other one's coming in and it comes in crooked, which it will, you know, come see me and we'll go ahead and fix it. But come soon. You know, the sooner you come, the sooner we can fix it. So, and people will come. So, especially if they're concerned about their kids' aesthetics or function or anything like that. So, what happens if you have something more severe going on? Like a class 3 bite, or they're having sleep apnea, you know, sleep disorder breathing problems or anything like that, you can always start with the habit corrector or a class 3 corrector, and we'll talk about class 3 correctors tomorrow. It's just a modification of a habit corrector for class 3 patients. So, you can go ahead and do that. What happens if you start too early? Now, you don't need to go crazy. You don't need to start in the C guide too early because it's going to increase the face height. So timing is key. Now, when we go back, if they have overjet, severe overjet of more than 4 millimeters, then you'll want to go ahead and start about 6 months before the first eruption. Those you want to start earlier because you need to grow a mandible. So it's kind of important. So do look for those small jaw patients. Okay, what happens if you don't do anything? Remember I told you I'm the Miss Cleo of the ortho world. I can predict across the room who's going to need braces and exactly what it's going to look like. I say the Healthy Start team has seen, no joke, I think we're up to, what, 3.5 million cases now in the whole Healthy Start, and last I saw 3.4 million cases. It's almost as much as Invisalign, but that's how many cases have gone through your Ortho, your Perfect Start, your Healthy Start, all that over the last years. There's I think it's a pipe. There's an incredible amount of data for us to be able to go in, see a mouth, see a smile at age 4, 3, 5, and tell you exactly what it's going to look like later. The jaws, the mouth, the smile, the profile. We've got that down to a science. So, and pretty soon we'll be able to present that to your patient. You'll be able to see it. So, and that's like, whoa, what are you talking about? So, we talked about that kid with this perfect pedo smile. Perfect, beautiful, like almost like denture teeth. If it looks like that, if it has no deciduous spacing, 91, you can use these stats, write them down if you have it, because this is incredible stats, you can back it up. 91% chance of risk of permanent crowding. That means without a doubt, you can confidently say this child will have crowding in their permanent teeth. Oh no, you know? But what if they have deciduous inside the crowding? What if they already are in their primary teeth and they're crooked? 100% chance they will be crooked in their permanent teeth. What about spacing? Spacing equals good. Whenever I see, I had big old gaps when I was a little girl, so, and they didn't all close. But you want ideal amount of spacing is 6 millimeters of spacing in between the primary teeth. Ideal. Even if they have less than that, there's still a possible chance for crowding. So do keep that in mind when you talk to patients, and talk to them about every appointment from any kid that has primary teeth, and have that conversation. Prepare them for what's coming. Give them their options. Sure, they can wait until they're 12, or they can do something now. Talked about the collagenous fibers and how it works. Slowly the teeth are going to come up. The way Healthy Start works is as we use the eruptive guidance, it's going to go ahead and gently widen the arch. So you've got the habit corrector, which is going to widen it, but as we start to move the teeth up one at a time into the right space, it's going to gently widen. The inner canine distance is going to increase on its own to the ideal width for that child. And we talked earlier about the lower arch. The right foundation to build your smile around is the lower arch, because it's something that generally doesn't move very easily, and it generally relapses quickly if you try to do it. So what do you do if you have a patient that's even more? What if they're like 13 plus millimeters of crowding? What if there's what if they're just crazy crowding in the primary dentition, like that first slide A? That is not good. So there's some early things that you can do even, and this is all options. You don't have to do all this stuff. Like Jill was saying, when she did her first 20 cases, she said, I just want easy. You know, I don't want any extra stuff. So you can just tune this out if you want to, but there are things that you can do if you have a really hard case, and they'll let you know if you need to do this. But some things they do is they do stuff to the primary dentition. Like in a slide B there, you can go ahead and bond the distal of a primary E. If you bond the distal of that tooth, it creates kind of like almost like a freeway ramp, so that the 6, when it comes up, is going to go ahead and come up distal. Now you've got a couple spaces in between those teeth. It's just composite. Later, you can buzz that off. You can use it. It's like it's been distalized, and you can go ahead and retract everything. So that's pretty cool. Sometimes they also bond to deciduous spaces. If there's any deciduous spaces, but you know it's going to be more crowded, you can bond them up initially while the space is still present. Then later you can zing it up and use the space. It doesn't have to be done. So we talked about eruptive guidance, that gets spaced with that, and then sometimes we strip posterior teeth. Again, don't have to do all this, so tune it out if it's too much for you. I don't like to freak people out. So again, if you have crowding in primary teeth, that's a problem. So you probably will need some additional stuff to go ahead and get there. We'll talk tomorrow a little bit about bumpers. Totally not something you have to do. There's some doctors with Healthy Start that say, I don't want to do bumpers at all. I'm not interested. Bumpers don't scare me as an orthodontist, because I did plenty of bumpers. I think bumpers are cool. But that's probably they have me talking about it. But we'll talk about it tomorrow. No worries. Okay, how does crowding work? Slowly, the teeth are going to come up. So you see that a lot of times, the shark teeth, the 2 rows of teeth, usually not a problem. If you see that on kids, the centrals, not a problem. Because once you lose those teeth are going to, even if you don't have the Healthy Start, the tongue is going to push those forward. The problem comes on the lateral teeth. Those ones, tongue doesn't push it forward. They'll come in crowded. So Healthy Start is going to just generally guide the tooth up into the right place and keep it there, and it's going to be retained there for life. So that's how that works, and it's fantastic. So how fast does this work? It works pretty darn fast. So during the active phase of the kid's time, you know, when they're wearing the CEG, IG appliances, whatever, you should see significant changes from appointment to appointment if they're wearing appliance. You need to have confidence in what you expect to see, which is why it's great. We can show you a lot of cases of what you should see from one appliance to the next. You're probably going to see your patient somewhere between, almost like you do with braces, the first, or like retainers, maybe 6 to 12 weeks in between appointments, kind of depending on what's going on, and they'll tell you what to do, what the best sequence is. But the first appointment is the most important. You should see significant changes. If you don't see changes, visual changes, they're not wearing it. And you need to have confidence going in because kids will live with you. Kids are just being protective. It's an innate instinct. They're gonna say, yeah, I did it. You know, and the parents can say, yeah, they told me they did it, so they must have done it. You have to confidently say, and it's the same thing with whether it's rubber bands that kids have to wear or something that's compliance related, or their Invisalign team, I have to confidently back say, no, you did not. In a nice way and in a fun way, but I'm gonna call them on their beep, you know, if they're not doing what they need to do, and say, look, I know you didn't do it. And the mom's like, oh, what are you saying to little Susie? Look, Mom, it's my job to give you what you need, what the outcome you paid for. And I've seen X amount of cases, you know, ortho cases, whatever, pick up a number. You know, I can confidently tell you she's not wearing it. And then, you know, that's strike one, like what Jill said. So, and then guess what? If they really want this, they'll wear it. But that's all right. We can go ahead and put metal braces on you when you get older, maybe pull out some permanent teeth. No, I don't want that. Okay, let's give this a try then. So, fantastic. So, but the cool thing is, and the little secret we're not going to tell the patients is, for most of the kids' appliances, your C, your IG, your G, you actually only need basically a couple hours, or you think even it's 1 hour of wear per night to actually have it happen. And you can actually make up that wear. There's a few exceptions. You can make it up, give it to them in the car. You can give it to them while they watch TV. I know you can find time to wear it. So you'll still get the results even if they're wearing it a little bit. A couple of exceptions is if significant overjet, again, of more than 4 millimeters, they have to wear it the whole night long. But I wouldn't even tell the parent that because you're always going to, again, under promise, over deliver. So, and kids, they'll always say that they're wearing it more than they are. You know, it's just how it is. So whatever they tell you, estimate they're wearing it 50% of what they told you. So tell them to wear it all night long. And if they want, there's no harm for them to wear it in the car, in front of the TV. Any type of appliance that I've had with my kids or anything that's requiring compliance, I tell my kids, you can wear it as much as you want in the car, as much as you want in front of the TV. Great, watch a movie. Fantastic. There's your 2 hours right there, done. So rotations, they should completely correct. If you have your 90 degrees or less, which is, it's all down to case selection, right? 90 degrees or less, it should correct in 1 to 2 months. So as long as it's coming up. Now if it's already up, now remember it's a different thing. So totally different. You gotta start the case early if you want predictable results. We're gonna flip through a bunch of results. You know, you can go ahead and just take a look at what you expect to correct, how it should look like when you correct it. It's great to just kind of see it. And these are great pictures that you can have in your office too, especially if you have a view book or like one of those like digital photo albums and patients are like, oh, wow, and we can give you all this stuff for access, you know, so you can use it in your office. We can make PowerPoints for you and stuff like that. So it's pretty cool because people will be, oh, that looks like so-and-so, you know, and that's what they do. What about spacing? So we talked about crowding. Spacing kind of works similarly but different. So anytime you have a spacing case, you're going from big to little as you consolidate the space, okay? So you're actually moving to a slightly smaller appliance. It's going to work differently. So spacing is slam dunk easy if you have overjet because you're just tipping it back, dumping it back. If you know overjet, it's a little bit more complicated, so trickier. So we'll go ahead and tell you how that works later. But basically, taking a space, moving it in, moving it back is how that's going to go ahead and work. What if you have unequal spacing? You have to take a look at your spacing. And remember, Healthy Start will go ahead, the diagnostics team will support you with this. They'll tell you exactly what to do. You have unequal spacing, it's all this way. You take a look at your arch constriction. If the arch isn't constricted, well then it's just unequal spacing. Maybe you lost a tooth early or something. So they're going to go ahead and they use something called labial lingual wires. All these things are just little bonus things. If you don't want to take a case like that to start, we totally understand. But it's super easy, don't freak out about it. If you can do dental school, you can do this. So basically what's going to happen, I'll show you, is where you're going to go ahead and poke kind of a, I don't know if it's O2O wire, through the appliance, and it just kind of provides a fulcrum for every time you put it in, it kind of pushes the teeth over one way. It almost works like an asymmetric midline elastic if you've ever used rubber bands before. But, so unequal spacing right there, same thing, like in this case right here, you've got a blocked out maxillary canine. No space for them to come down because the spacing is all kind of shifted off, probably lost a baby too. That's why you never take out like a baby C just on one side, or you take out both if you're going to pull them out for whatever reason, because everything will shift over, those front teeth, 2 to 2. So they went ahead and they shifted the midline to open the space for that tooth. So pretty easy. Speed of correction, again, super duper quick, but it also depends on the speed of eruption. You have to wait for those other teeth to come down. The teeth that are coming down are providing the force to move the teeth. That's why it's not a force that's external. It's the child's own natural tooth development that's moving the teeth. So it's pretty amazing. It's natural, it's not excessive force. It's just the way it's supposed to be. Okay? So usually correcting spacing is going to take about 2 years. It's natural, and we're talking about anterior spacing. We're talking about 2 to 2, top and bottom. So if you start at 5, you're done at 7. Now, does that mean you're done with your Healthy Start treatment? No, not completely. I mean, you can be, and there's some doctors that will go ahead and discontinue it once the front teeth are straight. Most doctors will go ahead and stick with it. They'll put them on kind of a retention phase, just like you would with a phase 1 to a phase 2 retainer patient, and see them every 6 months, have them wear their appliance at night, and until they start losing more teeth. And children will do that. They'll lose those front 2 to 2 pretty fast, and then there'll be a waiting period. My son is 11, and he's a big 11. He's almost as big as me. He's only lost, well, there's like a 2.5-year lag between the 2 to 2, and now when he's finally starting to lose his 4s, I know I talk ortho, and his 3s, so it's starting to go again. But there was an entire lag where literally it looked like this. So 2 to 2, that's it. And it's pretty funny because he's like a big boy and he's only 8 permanent teeth. But talk about development, boys are different than girls. So, okay. What about spacing? Overbite, which I call deep bite. So overbite, you've got to correct it. Overbite is one of those things that does not get better with age. Again, Miss Cleo, predict it out. You see a kid with a deep bite, you tell mom it's going to get worse with age. I'm the perfect example of that. So I was the kid with the pretty nice teeth, no crowding, excessive spacing, had a little tiny gap right there about by the time the permanent teeth came in, about 1.5 millimeters maybe. No big deal. I kept begging for braces. Please, can I have braces? As a matter of fact, I was such a fan of braces, they could have predicted I was going to be an orthodontist, that I constructed my own out of paper clips, now-and-laters, and I would wear it at school. I constructed it so accurately, and I used to wear it at school, the teachers thought I had a retainer, and I wouldn't wear it until I ate it now-and-later and then I'd do it. So, how old am I now? How old was I? That would be 3rd grade.
That's hilarious.
So, have you never heard of people doing that before?
I have, but I've never met one.
So, I know, and I just, hey ladies, come have a seat. We save seats for you right here. Come on in. We're talking about,
Hey, nice to see you.
Great to see you. We're talking about braces. We're talking about deep bites. So, we're talking about making your own retainers out of paper clips when you're a kid. I don't know if anyone's crazy like me. But yes, it was I wish I had taken a picture of my contraption. But it was so awesome. And then now I hate making retainers. If you told me to make one out of steel, no, I don't do lab work. But in any case, okay, so anyways, back to my ugly teeth. So I had a deep bite, but nobody knew about it. And I don't know why my pediatric dentist never said anything, because I guess it wasn't that deep. But remember, deep bites get worse with age. So what happened when I was 17? I'm going to tell you what happened. I was biting on the roof of my mouth, big old trough. I ran and I literally was bleeding at times. I was biting so deep. And I was biting up on my 8 and 9 here, so that had fragments of the teeth. Constant trauma of biting. So when I bite down, they'd wiggle. They took an x-ray, I had no roots left on my front teeth. Believe it or not, I still have my teeth, but I will not bite into pizza crust. I can't bite into bagels. I can't eat anything because I will lose these teeth. So it's very, very sad that they didn't catch my deep bite earlier because I did trauma, right? My husband always goes, oh, you're gonna need implants. I'm like, oh God, can you make them, just give me all veneers now, I'm gonna look awesome. But he doesn't want me to be his patient. So in any case, but yes, please catch your deep bite patients early. Let the parents use my story. Say, I have a friend that this happened to it. You don't want this for your kid. You don't want this for your friend's kids. You don't want this for any of your patients. Be insistent. Be a pain in the butt. Tell them about it all the time. Overbites, deep bites must be treated. It's a health issue. It is a health issue. And that's what a lot of parents even know. Even if it looks nice, it's a health issue. So in any case, age 17, guess who got to have braces? Me. And it looked terrible, and I had no prom date, and that's probably why my grades were great in college. That's probably why I'm doing what I'm doing, because I was a geek. But in any case, yes, it did give me good grades because I had no social life because I had braces. But that's why I like the liners. And which wore my roots off more, and now I have less roots. But the story of the deep bite and why I don't recommend it. Okay, so we talked a little bit more about this, and we've talked about how Healthy Start works and the kids' appliances work. That the cool thing is that we've had so many cases we've done doing all their sacks going down and in the floor. We know that our treatment does not lengthen the face, and this is the main thing for orthodontists. if you do talk to them, gosh, does it deepen the bite? Does it increase the face height? You know, what other side effects or symptoms happen? Actually, no, it keeps the face growing in the right direction, which is down and forward, which is great. What about overbite? Okay, now we're talking about, oh yeah, I'm still talking about overbite. Same thing, deep bite. See, it throws me for a loop every time I do it. Okay, how quick? 0.8 millimeters per month. It's a little bit slower, okay, than it is with the crowding. So, but you know, this patient here has significant overbite right there, deep bite right there. So it's going to take about 6 months or so. Overbite correction is fragile. It is one of the things where, like some other things, that a few things where you do need to retain it. You may need to wear your last appliance 1 night a week to retain it. It will get deeper. Same thing with me. I have a bite plate on my retainer. If I don't wear the darn thing at least 2 nights a week, I start hitting my palate again. So, have to do it. Overbite corrections. Take a look at the pictures. You can kind of see what's possible. Pretty cool. It's fragile. You have to retain it. But we're not talking about every night. We're talking about 1 night a week. Gummy smiles, kind of in the same lamb as your deep bite and your overbite. So a lot of people that have overbites have big old gummy smiles, and this is something that patients will complain about. They will come in saying, I don't like all that gum in my kid's smile. Can you treat that? Yes, we can. Now, if they have a deep bite, it's super duper easy because you're going to go ahead and intrude the teeth with the appliance, which is going to provide a natural force to intrude it, and you're going to get relative extrusion of the back teeth to open up. So you're doing it 2 different ways. If there's no growth left, probably not going to happen. So you need to have growth left, you need to have a deep bite, not that stable. So same thing there. But also the cool thing you can tell them is most of the deep bite cases and the gummy smiles combos are girls, just the way it is. Part of that is just facial musculature. Girls tend to smile like super big and their lip goes up, kind of like a horse. But that's how girls are, you know. But as they age, their lip takes a different position. It slowly relaxes. If it's a real big problem, like in a teen or something, you can use Botox, oral Botox. Can you do that here in Texas? No? No fun? Okay. But you can. So it actually works really, really well if you have an adult with a really gummy smile. So it's pretty cool. Great way to get income, but sorry, Texas. All right. Okay, gummy smile, more pictures, same thing. I don't think this girl's too gummy, and it doesn't really bother me, and that's normal for me for a 7 or 8-year-old girl, but if she has a deep bite, yes, we need to correct it, which we do. So. Okay, Overjet, our favorite. And of course, every time you see an Overjet, what am I doing? Crystal ball, I'm going back to the habits. I'm going to say, which thumb do you suck? Which finger do you suck? And if they don't, okay, sorry. But in most cases, there probably is a habit or was a habit. Dig it out, find out what it is, because you're not going to treat it if you don't eliminate the habit first. So just get chummy with the kid, be their best friend, you'll get it out of them. Kids are easy. So yes, you need to correct Overjets. Overjets don't get worse unless there's a habit, but they don't get better really either. So, gotta correct them, okay? And you'll see them at a young age if there's a small jaw. So speed of correction, pretty quick. It corrects pretty quickly. 6 to 8 months or so for a 6 millimeter Overjet, not a big deal. What happens if you don't correct it young? If you don't grow the mandible, well, what are your options? In that case, once they're 12 or 13, they're done growing, you can use elastics. Elastics, rubber bands, all it does is just tip the teeth. It angles and cants the teeth in order to match it up. Not that stable, gonna have to wear your retainer every night. So a little different, or you can do a jaw surgery. Here's some Overjet corrections, what you can expect again. So there's some pretty dramatic Overjet corrections. It kind of blows my mind when I see some of these pictures because I say, no way. If I just looked at the left side, or these kids walked into my ortho practice, and granted they're pedo kids, most of them, some might be 7, 6, 8, but I would say, especially this one right here, I would say no way, no way. Full step class 2, that's probably a habit patient, no way that's going to get corrected, that's a jaw surgery case. And I tell the parent, we'll give it a try, we'll do some phase 1, maybe we'll try functional appliance, but you can anticipate you're probably going to need jaw surgery later, especially if they have a small jaw. And the parent's like, crying. But now I can more confidently say, we can give it a try. We have a couple tricks. If we start early, early means 4, 5. It doesn't mean 7, 8. So earlier is better. What about open bites? We talked about open bites before. You guys all know about that. Yes, we can treat open bites. We're calling them regular open bites. I'm going to call those dental open bites in my world. Not a skeletal open bite. We talked about how to identify a skeletal from a dental open bite. You're looking at long face heights. You're looking at antegonal notching, steep mandibular plane angles, all that kind of stuff. And if you can't tell, our diagnostics team can help you, so don't worry about that. We'll tell you which one's going to work and which one's not. How quickly does open bite correct? Pretty fast. If it's a dental open bite, it's actually quite fast. Of course, if they have primary teeth in, it's a lot quicker than if they have permanent teeth in. So much quicker, because we talked about the eruptive guidance and all that. The fiber's not being mature, so it's a lot easier. But if you're struggling with the open bite, if the habit's not going away, if the tongue thrust isn't going away, you're not getting the compliance, you don't want to give them the kid yet, you can use permanent habit appliances. So there's ones that you can do fixed, and the other appliances can go over it. So do not fear. There's always kids like that are having a hard time. Don't give up on them. They want to correct themselves. Consider it, and we can help you with that too. Crossbites. Crossbites are not all the same. So you've got full skeletal crossbites we talked about earlier. You might need to have a short or something a little bit more. If you don't want to take those cases, that's fine. We can refer them out. But a dental crossbite or a crossbite with a shift, yes, that can just be corrected with a habit corrector. So, and then you can move on to your kids' appliances, your CG or IG. If it's a class 3, you can use a class 3 appliance. It's a modified habit corrector to go ahead and jump that bite, and it'll correct relatively quickly. Tomorrow we'll talk about class 3s. What about teeth that are just dumped back? Front maxillary teeth that are dumped back? Yes, and often that's a result of the lip just being really strong. It'll correct with a habit corrector, self-correct, but yes, it will correct. Give them a nice, beautiful inclination to support the lip. Okay, so we're moving up right now, right? So now we're on kids. So what are the contraindications? We talked about with the little itty bitty kids, we can do 13 millimeters of crowding. Now we're getting older. Now it's 8 millimeters of crowding. We're getting a little more limited, okay? Closed lock TMJ, it's on everything. Skeletal open bite, skeletal class 3 malocclusions, it's on everything. Another one that just popped up, cleft lip and palate. Okay? We're not going to go ahead and do that. We're going to refer those to Ortho. That's a special gift for them. Special kids, refer them out. We're going to flip through some cases now. Just real quick, there's about 30, 40 slides on this, so, but if you want to go ahead and dig into them more, we can. But the idea is for you just to see these cases, see what's possible, make that list. What do we call it, the kill list? Is it the kill list? I think it was the kill list. Make that list. As you start to see these kids flash up, I want you to think like, gosh, this looks like little Susie in my practice. This looks like little Johnny. Who was that? Be texting your TC. You got them here, some of them here. Who's that girl? Make your list, because you know who you can help. Okay? And even if you see a kid that might be too old, think about their siblings going down. Who's going to be easy for you to start with? Think about their little siblings, okay? And ask those kids if they have any cousins, and start with them. So this first one we're going to see is a Lauren F. I think all these are girls, but I don't know what that is, but that's just what it is. But I can tell you ahead of time.
I'm sorry.
Sure.
I was going to pass some of these around.
Yeah, pass them
Where are we
around.
on?
Oh, smart move. How about
Sorry.
just pass
Just
everything,
okay.
except for the snore cure.
Yeah, have a Sorry, I didn't do that.
Great idea. I should have done that. Okay, so Lauren F. Just to give you a head. And again, you don't have to come up with the treatment plans. We kind of do that for you. You can go ahead and move it around, if you have feedback, but we'll tell you what we think is best, because they've, like I said, 3.5 million cases, 3.4, so they know what to do. So all the cases start with the habit corrector, then they go on to your C or IG and move on. So this one just had a habit corrector and the kids appliance, that's it. So 16 months. So she started with a gummy smile, your overbite, deep bite, okay, and overjet, and some crowding. And she's a mouth breather, a lot going on. So here's Lauren F. right here with that in mind. Just go ahead and take a look at these pictures. And I like this because this is the sequence of appointments, okay? So we see the initial, then remember they're not coming in every week, they're not coming in every month, they're coming in every few months depending on what phase of treatment they're in. So you can kind of see how infrequently you're going to see them in your office. It's not that much. And except for the first appointment, the diagnostic appointment where the doctor's going to really talk to the patient a lot and kind of figure out if they're a good candidate, and maybe the first one when they come back, the progress appointment, the compliance appointment, hey, let's see how you look. Most of these appointments can be staff. Okay, 90% of your appointment is staff time. If you want it to be, if the doctor loves it, go ahead. But hey, let's take a look. Let's see how it's fitting. Let's check. Just count your teeth. Super duper fun. Really easy stuff. So 3 months later, they saw the patient. You're starting to see some progress, especially on the deep bite. I can totally see a difference. 2 more months later, 6 more months later, we're starting to lose some teeth. Now this is a great case because you started early, directive guidance coming on in. Look how much the bite is opening up. Look how much the overjet is going away. This is incredible. You're not seeing them very frequently. This is quite infrequently. This is all the appointments that they have. This is in almost a 34-month window. How many times do they see them? 6 times? Not too much. Very little chair time, and your staff is doing most of the work. And it's fun stuff. There's nothing scary. There's no discomfort. It's all about compliance and fun and rah-rah. Do have a reward system. Have stuff you can give. Let them know what the rewards are going to be. And customize your rewards for the patient. That's the beautiful thing. It's not very much to go to Party City and get a few little things. Give it to them. Then that's the whole reason I used to like to go to the dentist when I was little, is because they had the best rewards. Stuff that I wasn't allowed to have. There was like balloons and gumballs, and I don't know what we were allowed to have, but it was really fun every time I went. Stickers. All right, here's Lauren. Here's the lateral images. Check out this overjet just correcting. It's pretty impressive. Same frequency. Okay. Oh, I think these lower ones are upside down. Oh, they're in here. There we go. And I love watching the way these teeth are just slowly moving forward. This will not happen if you do not have a corrector. It will definitely not happen. Here's Lauren's facial photos, okay? Usually, by the way, when you take facial photos, you're supposed to close your lips, but she's so happy she's smiling in her pictures. So we'll go ahead and take it. But, yeah, cute. Oopsies, woo! John. What'd I do? Don't look at all the stuff! Uh-oh, encountered a problem and needs to close. I crashed it. I got all sorts of stuff in here. Launch that back up. Yay! We're back. We finished, Lauren. All right, we're on Carrie now. More girls, more girls. Okay, this one, Overbite and gummy smile. Should be pretty easy. Habit corrector, CIG. Not a big deal. All right, Carrie. I won't take you through the whole thing again, but you kind of get the idea, okay? So basically, pretty fast. They saw her, just a couple times. Pretty simple. She's just wearing her appliances. Healthy Start will tell you when's a good time to switch your appliance out to the next one. They'll tell you exactly what to do, and you can check in with them periodically to go ahead and show them your records, see how you're doing. Yes?
Were you sending in photos along the treatment process?
There is check-in guides. I'm going to go ahead and let John, you want to kind of explain the check-in? I know we're going to go over that more a little bit, but just to kind of preface it, what is standard check-in process? You know,
Check-in,
like progress along the way when they should switch.
Oh, perfect. Basically, when we start noticing it, usually I just like to take pictures, and so I can show. I always have the models there, so we can just show. Look at how the difference is, and that's I think one of the best ways. But I think anything significant is good to always have photos and stuff like that.
So you're not required to send this stuff in, but you know if you have questions or concerns, you can
if you
send
have
it in.
any questions or concerns, definitely, and they're really Dr. Bergerson will respond to us. So, yeah.
We'll go over the diagnostic needs, what you need to submit, and when you need to submit them. But these cases, because there's been so many that are treated, they pretty much can already predict where it's going to go. They're actually completing this online software as well that will digitalize the whole petition and where it'll go. Healthy Starts is a super generous company. If you ever want a case review or a progress check, you can take it in and send it in for no additional fee. Personally, in my office, I take photos every 3 months. I did it more often in the beginning just so that I could build my workbook, but now I take them about every 3 or 6 months so that I can help the parents see the progress we're making.
Thank you. They're always there for you, and they've got a team that's on staff, and then you'll also get connected to the doctor and the clinical instructors. So you can, if you have your favorite one, I'll send them all to Jim. So you can go ahead and I think we all have our different strengths, right? So different questions might go different places. So there's Carrie again, lateral photos. I love this class, this occlusion at the end. This is just incredible. It's really beautiful. Great class 1 occlusion. Got lower on the upper again. And there's her final, and she went from really gummy to a really nice smile. I really like this smile here. It's a significant difference. And remember, the gum smile will improve, but it won't improve that much. So that's a really, really pretty smile. Profile, fantastic profile on the right side. This is an extremely aesthetic profile. And I don't know if you're like me, where you notice everyone's profile and make a comment on it. And my kids and I are always like, you know, long face, making little comments. But I'm creating little orthodontists in my house. But they notice profiles, and there are aesthetic profiles. There are profiles that are considered harmonious, and there are profiles that are not harmonious. And sometimes parents don't know what they don't like about the look of their kids, and they're pretty blunt. They'll be like, I don't like the way he looks. He doesn't look. So today we're going to be talking about, first of all, let's start about for adults. What makes a patient an adult? We kind of talked about that yesterday, right? Anyone?
Yeah.
Adult dentition.
Adult dentition, right. What else? Puberty. Go girl. Okay, puberty. So we got to have that conversation with the patient. We got to really dig in and find out, are they done growing? You can't just look at your medical history form. Usually it has like, has the patient begun menstruation? That's all they have. And half the time the patient's not even honest on that form. So, or the parent doesn't even know. So you have to ask questions. So you can dig in and ask questions, but hey, they could be doing that next week, and you know, now you just figured that they're still a teenager. So you got to really dig into it. I like to ask a lot of questions, fun questions. For the boys, I ask a lot about shoes. So I say, hey, what size shoes do you wear? They're like, what? I'm 11. Oh wow, that's pretty big. Gosh, how long have you had those shoes for? They're looking at their Jordans or something, and they're like, oh, these are cool, yeah. I only had them for a month. Gosh, how often do you get new shoes? You know, do they get tight? Yeah, I'm still getting new shoes all the time. And the mom's like, oh my God, these are so expensive. Keep having to buy him new shoes all the time. Okay, he's still growing. That's easy. So feet is for boys, seems to be the last thing to grow. And you can listen to their voice and look for presence of facial hair. That pretty much solves that problem. For girls, you can ask questions about that too, but just really, you know, digging in, asking questions about, gosh, you know, are you getting taller? But honestly, the best way, the gold standards, there's 2 gold standards for me, and the ortho residents have to get these all the time. We have to go to the pediatrician and get the growth charts. And there's nothing wrong with asking it. It's what's so funny with my son. My son's 11 and he's not growing yet, but our coach actually asked for his growth charts since he does a kind of semi-professional swimming already, so he swims at a national level. They flat out asked for his growth charts because he wanted to see, because he gives certain type of training depending on whether or not he's growing. And if he's not growing yet, he doesn't get the same kind of CrossFit training that the older kids would get because their muscles aren't ready. So we're pretty aware of when he's growing and how tall he's going to be and when it's going to start. So fun stuff though. Kids love to learn about that. So the other way that you can find out, the other gold standard that I know a lot of doctors are using, and I think Dr. Jill said she's using it, is the hand wrist x-ray. And you can use a regular Ceph kind of x-ray or Combbeam CT x-ray to take your hand wrist. There's a great article, and if you email me later, remember my cards are up here, I can give it to you, that tells you step by step how to go through a hand wrist or x-ray. There's a certain bone that only shows when they're done growing. So it's called the sesamoid bone. Boom, you see it, they're done growing. Or they're like 90% done growing. So if they're pretty much done growing, they're an adult for a healthy start. Okay, so talking about that also, let's talk about why would a patient want to do healthy start? Why would an adult want to do healthy start? It's a kid's appliance, right? Well, I mean, it's a trick in your tool shed. It's a trick in your tool shed. It's a tool in your tool shed. It's a trick up your sleeve. So it's something that might fit some patients and might not fit other patients. So it's important that you understand it and then you find the right fit for patients. So for example, obviously I'm an orthodontist, so everything I'm thinking about is orthodontic related. So when I have a patient, but for GPs, this is what I recommend, and my husband's a GP. So he looks at every single hygiene patient as a potential ortho patient, not because he wants profit, and yeah, he would like that too, but also, hopefully he doesn't hear this, but also because it improves perio. For all you hygienists out there, it improves perio. For you dentists out there, what about wear, abnormal wear on teeth? Restorations breaking down, abfraction, stuff like that. If you're seeing that kind of stuff going on, TMJ issues, most likely their bite is imbalanced. So combination of 2, vast majority of adults probably could use some orthodontic treatment. Their teeth are going to last longer. You're not going to have to do partials or implants or anything like that. So do offer it. It is gold standard. It's standard of care to offer this to every single patient who doesn't have perfect occlusion. They may choose not to do it. Revisit the conversation every 6 months and let them know it's out there. They're always thinking, gosh, money, or ew, it's ugly, or it's not aesthetic. Not necessarily. There's a lot of options out there. I recommend that all GPs have 3 types, and this is me, not Healthy Start, but have and orthodontists hate that I say this to GPs, but you guys have the most potential patients. I mean, we have to wait for somebody to refer us a patient or we have to market. You guys have patients every single day, new patients that you could potentially see for ortho. Gosh, you should be doing ortho all the time. You should have 3 options. You should have a removable option, like an aligner option, be it your Invisalign or one of like 20 other aligner companies that are out there. And if you don't know what they are, take my card, talk to me later. I know them all. Number 2, you should have a fixed option, because not as much as I love aligners, not everyone is going to be compliant. Like Jill says, with kids with their barriers, adults have every single barriers to ortho, and they'll spout them off. Well, it looks ugly, I don't like it. All right, well, what about aligners? They don't look ugly. Well, I won't wear them. Okay, well, how about braces then? We have completely white ones that we have, you know? I don't like anything bonded on my teeth. Okay, well, then you got Healthy Start. So this is where it comes into, for the patient that has the barrier, I don't want attachments on my teeth, or I don't want braces on my teeth. Yes, there are aligners that are attachment-less, but they don't work that well. But you gotta wear those 23 hours a day. What about the patient that says, I won't wear them during the day? There's plenty of patients that will not wear the aligners you give them during the day. They're not gonna wear them, they're gonna say they're gonna wear them, and then you come to do the treatment, they're not gonna wear them, and they're not gonna get any decent outcome. Because aligners are hard material, they're static material. There, you have to wear them 23 hours. It's a completely different material than the Healthy Start material, which is elastomeric. And I'm assuming we passed them all around yesterday, but I'll just kind of pass them around again, just so you can kind of see how they feel, how they're different. So they have an elastomeric modules of elasticity built into them, so they move teeth more efficiently. So what happens is you only have to wear these darn things at night, plus 2 hours of active wear during the day if you're an adult, if you're done growing. That means they do need to bounce on them during the day. There's no adult that can give you the barrier that they can't do that, because the fact of the matter is I can definitely find 2 hours in my day every day to wear these darn things. I'll wear them in the car, and you can ask them the questions, just like Jill said. Hey, tell me about your schedule on Monday. When do you get up? Oh, 5 a.m. Great, how long does it take you to do your hair and put on your makeup? An hour, boom, hour right there. They're not talking to anyone when they're doing their hair. You know, cooking, in the car, watching TV. I'm sure they can find 4 hours in the day they can wear these darn things. So it's not a big deal. But yeah, so that's basically what you, and then on top of it, that's just alignment we're talking about. What about the patients that have habits? Plenty of people do. Or malocclusions, or sleep disordered breathing, or bruxism. This is, I mean, I would never give a bruxism patient an Invisalign, because they're going to blast right through it. They do. They blast right through it, and they don't even make it through the week. They're already on to the next one. It doesn't fully protect the dentition. This one is much better. So find your right fit. And also what else is going to happen is you're going to have these kids, your kiddos you're seeing, and they're going to have parents, and the parents are going to be like, I want that. I don't want Invisalign. So another option there too. So you got to understand, what can Healthy Start do, what cases are ideal, and if you don't have an ideal case that you think is for an adult, you need to have that conversation with the parent and let them know, these are the outcomes we can attain, these are the outcomes we can't attain, this may be a compromised case, it may not be an ideal case. Have that conversation. Always put your conversation in writing. Always make sure we documented, we talked about this, the following things we can do with Healthy Start initial. The following things, and this is just my tip, just because I've been burned before, and I've seen way more dentists get burned than me. I've only probably been burned once. I always document every conversation of what the treatment appliance can do, and remember, under promise, over deliver, and what it can't do, and what their other options were. Also gave the patient option for Invisalign full. The following things would have been done with this, or traditional braces, referral to an orthodontist, patient declined other options. Sign, you sign, they sign, boom, done, put it in the chart. Conversation done. So later if they have to say, you didn't fix this tooth. Yeah, we told you we weren't gonna fix that tooth, and we gave you your wrist, in a nice way. Oh yeah, I forgot. Okay, so, cool, let's talk about what Healthy Start can do, the adult appliance. So we went through it yesterday with the little kids and then the preteens, so you're gonna see this list slowly getting more restrictive, but it's okay for very small crowding. 2 millimeters, that's not much, but you can do IPR. So for all those of you who are Invisalign providers, you probably are very comfortable with IPR. So you do IPR, you can do more, no problem. It's a little bit minor overbite and overjet, okay? If there's no crowding, the correction is pretty much coming by space closure, or just for the overbite, or deep bite, it's coming just from relative extrusion of the posterior teeth and absolute intrusion of the anterior teeth. Not incredibly stable. We'll have to wear your last appliance 1 night a week, most likely. Rotations, we're now down to 45 degrees, okay? And it does not rotate posterior teeth, only anterior teeth. So that but we can do more, but there's buts. So we're gonna go over later. There's some auxiliaries or adjunct things that can be added to the appliance that can give you more. If you like that kind of stuff. If you don't like that kind of stuff, plug your ears, don't have to listen, it's not necessary. So holding doesn't have to be a part of Healthy Start appliance system, but I'm gonna fly past it, and if you want to understand it more, you can email me later. And it's all also in the online training if you really want to dig into it. Dr. Bergerson is the founder of Healthy Start, and he loves that kind of stuff. Your bumpers, your cleats, stuff like that. Most of our doctors are like, I don't like it. So, it's just not in their comfort level, so no problem. And crossbites, you can do it with some auxiliaries, minor stuff. What does it not work for? Let's go here. Contraindications, open bites, not really. Skeletal class 3, same thing as yesterday. They can do pseudo-dental class 3s, and we'll talk about class 3s in a minute. More crowding, unless you have bumpers or IPR. Most of you are probably more comfortable with IPR than bumpers, but we'll go over what they are. I still like bumpers. Overbites, overjets that are too much. Posterior spacing. Many missing teeth because you need a fulcrum. You need a contra moment. Probably doesn't make sense, but it doesn't work. And tip canines. Okay? So, let's go back to where we were. Okay, remember, every Healthy Start appliance system is going to start with the adult teen habit corrector. Just a little bit bigger than the kids one. Same thing we went over yesterday, don't have to talk about that. Then it's going to move on to all that alphabet soup of appliances, just different sizes depending on whether or not they've had premolars extracted in the past, upper, lower, etc. Don't worry about NT, X, U, anything like that. The last appliance is used as a retainer. So, and remember the cost of the Healthy Start appliance. Your lab fee is approximately $600, plus or minus, I think more $600 to $700. I just jumped on the Invisalign portal this morning and I took a look at their recent fee hike that came up. Invisalign Teen, I believe, is $17.99, $17.99 plus by their retainers. Now you're looking at over $2,000 for a lab fee, unless you're extra special and you're like a preferred elite 1% provider or something like that. $2,000 lab fee versus a $600 lab fee, that's a big difference. So either you're going to take home a lot more money or you can lower your price for your patients. I don't really care what you do, but something to keep in mind, as you're kind of comparing apples to apples. So, but I would say Healthy Start Adult is kind of more like your Invisalign Express 10 to Invisalign Lite in terms of what it can do. So but still the lab fee for that I think was $925 plus retainers. So that's $1,100 still. $500 cheaper. So something to keep in mind, and they only have to wear it at night and 2 hours during the day. And you don't have to bond attachments, blah, blah, etc. All right, talked about this already. How does it work? Like I said, it's more of an elastomeric material. So it's got a modulus of elasticity. They do need to activate it during the day and then wear it passively at night. It's gonna rotate those teeth pretty darn fast. So pretty easy stuff, no brainer. It works just like a positioner. So sometimes we have to use auxiliaries. We'll kind of get into those later, either IPR or bumpers. Widening the arches gives us space too. Do dig in to find out if your patient is still growing because you're not going to get as great of an outcome if they're not. Check your contacts. Run the floss through every single contact. If it's tight, if it's snapping, you need more space. You might need to do something, whether expand the arches, use a bumper, or use IPR. Major overbite and overjet corrections, probably not going to happen too much. So you can always straighten the teeth and you can just have the patient sign a release saying that they realize they're not going to correct their bite, and most adults are fine with that. But make sure you give them their options. You can say, hey, we could have done Invisalign Teen or Invisalign Full. We could have used rubber bands. Rubber bands are not a component of Healthy Start. There's just no way to run inner arch elastics. The way rubber bands work, if you guys don't know, with your braces or with your aligners, is they're going to go ahead and tip the dentition to get it closer together. It's not necessarily a stable movement. As soon as you don't wear those retainers, it's going to go back. So it's not growing a jaw. We talked about the parameters, so you can kind of see what you can get. So you can IPR to get space. You can use a bumper. So a bumper, we'll get into it later. A bumper is a distalization appliance. And you can just straighten the teeth. All of that will get the bite looking better. Here's what the appliance looks like. We've seen all these. You see how slowly it starts to fit in to how it is. Also, when we start adults, the other way we start adults is when they have their second molars in. So they need to be done growing and or second molars is an adult appliance. Went through that. Inappropriate cases. Inappropriate cases, obviously, you're looking at A, you're going, wow, that's a jaw surgery case. All the teeth are in, they're done growing, not much we can do. They got a little bit of improvement just wearing the bumper. So just distalizing and pushing all those teeth back. But the vast majority of adults are probably not going to be too into a lip bumper. So I don't think you're going to have a lot of treatment acceptance with that, but it's just another trick in your bag of tricks. Lower crowding, pretty easy. You wear it 2 hours during the day and all at night. And it just rotates the teeth. If you have a tooth that's more than 45 degrees rotated, you'll need something called a pleat, and I'll show you what that looks like later. It almost is like an attachment for Invisalign. It's pretty quick. Lower crowding right there. And upper crowding. That's a pretty great result right there, number C. That's a very good result. This one I think is a little different, and maybe I'll ask Jill about this. Jill's here, yeah. What's up with the denture powder? How does that work? Just, it's a trick to help get a better outcome. Do you ever do that?
You know, I don't, especially with these appliances because the teeth fit into it, so I've never had to use it. I've had a couple of older kids with a really strong anterior tongue thrust or a really, pretty much just the tongue thrust, that I'll use the denture reline to lock their teeth into the posterior after they haven't been able to wear it for 2 to 3 months. But no, I think you could actually even remove that off of the slide. Okay. Many doctors that are using it, and definitely last case.
Yeah.
Last resort.
I was just curious, yeah. He has a couple interesting things here. And a lot of these tricks are ones that Dr. Ferguson used 30, 40, 50 years ago. So, but you know, there's some doctors that do stuff like that. I'm not sure. Here's your Overjet, Overbite right there. So nice correction right there. Most likely had a bumper. Overjet. Very nice. Crossbite. So there's your cleat right there. Let me go ahead and turn this on. I have this mini toy. See the bumper? See the cleat right there? So a cleat is something, my understanding is that they teach you, they tell you where to put it and they put it in. But correct me if I'm wrong, and this might be another Jill question, they can put the cleats in for you, right? If you ask them to?
Yeah, they can. And that's a great way to do it. The cleat is really just allows that last little rotation perfection. And they'll either draw a diagram of where to put it or they'll put it in for you. So
I like to put it in for you.
yeah.
But yeah, I mean, you just have to be really, really honest with the team in the lab with what type of lab work you feel comfortable. Some people are really hands-on. They like to do stuff themselves. I want to do it. I want to learn to do it. Great, go ahead. Yes.
They're really easy.
Okay, John will do it for you.
Yeah, I'll do it.
Well, I just don't want to scare anyone initially because sometimes, you know, new providers are like, oh my goodness, this is so scary. And essentially, it works biomechanically the exact same way. If you ever seen nail liners that have those divots or the dimple pliers that you put in, it works like that. Exact same thing. And who knows, maybe we can find a way to do dimples. But yes, it's like a tiny little staple that moves the tooth. It's pretty cool. Crossbites. So if you want to really go crazy with adults, you might need auxiliaries. We talked about cleats. We're going to talk more about bumpers, but we talked about some of these yesterday. Oopsies, wrong button. Schwartz's, quad helixes, RPEs. I'm the queen of those. If you have any questions, I can help you with those. So, I mean, that's ortho, but easy ways to expand a palate, but a lot of tricks that you need to know if you want to learn it. It's not part of the Healthy Start treatment, but if you want to take on harder cases that maybe Healthy Start alone can take, you might need to have some extra bonus items, and I can teach you how to do that. So again, take my card, ask me if you have questions. Crossbite's pretty easy as long as you try all the different things. All right, so with that in mind, we took something that was very complicated, made it pretty simple. We'll jump into class 3. Class 3 you should know about because class 3 appliances can be treated with Healthy Start. The class 3 appliance looks very similar, and we'll jump into it as the habit corrector, but it's basically a modified habit corrector only for class 3 patients. So class 3, we talked about it yesterday, it can be inherited. So skeletal class 3s we don't take, but pseudo class 3s we take, or dental class 3s we take. So you need to know the difference between a skeletal, a pseudo, and a dental class 3. And if you're not sure, you can send pictures, even if you don't want to do the diagnosis, to the Healthy Start team, and they'll let you know. That's one of the benefits. So, but habits can make a class 3 worse. So if you're constantly moving your jaw forward, you can actually intensify a class 3. Or if you have kind of a slide or a CRCO shift and you're sliding forward instead of back, it can grow you a mandible. So we don't really want that. Or if your tongue is constantly sitting forward or swallowing in the wrong direction, it can encourage the mandible to grow or push the teeth into a class 3 position. So research has shown that class 3 will get worse over age. So it's one of those things, remember I said, get out your crystal ball and be a Miss Cleo. If you see a kid with a class 3 bite, it ain't getting better, it's getting worse, okay? Now, different things, if it's a mild skeletal and we catch it super duper duper early, I'm talking like your toddler kid's time, you can probably treat it with Healthy Start. But do take pictures and double check, because it really depends on the etiology of the class 3. So class 3s that are mild skeletals could be caused by a small maxilla or a large mandible. So you'll want to dig into and ask questions. Hey, I mean, sometimes you see the mom or the dad and you're like, okay, I see it. But you can say, they say, I don't know where they got it from. Well, is there any uncles or aunties that have that kind of facial profile? And you don't want to make the kid feel bad. They get all freaked out like, oh, what's wrong with me? I didn't even notice that I have a big jaw or a small jaw or something like that. So, just, it's awesome. I mean, there's plenty of celebrities that have class 3 profiles. Look at Reese Witherspoon, very strong class 3 profile. So we don't want to say Jay Leno because maybe that's not too aesthetic, but finding ways to let them know what the risks and benefits of a class 3 profile are and how Healthy Start can treat it. But other things that can intensify when you have a class 3 is your TMJ, joint disorder, abnormal occlusion and wear, speech interference, jaw discomfort, and wearing of teeth. So a true skeletal class 3, usually these are going to present in your office. It looks very different than some of those like habit-related class 3 or habit-related open bites. So a true skeletal class 3 often is going to have an open bite, but not always. But in most cases, you're going to see occlusion, usually more on the posterior teeth, and you're going to see a steep mandibular plane angle. And you can even see the asymmetry in the profile of the jaws and everything like that. Most Asian populations, and there's studies that back this up, depending on what part of Asia they're from, kind of changes their class 3. So Koreans tend to have a very, if I get this right, small upper jaw. It's a small maxilla for Koreans, whereas it can be the other way around. Some other Asian populations can have a large lower jaw. Upper jaws are done growing by age 7 or 8. So that class 3 is going to be the way it's going to be. Whereas lower jaws, if you have excessive mandibular growth, is going to present more like 16, 17, 18. So got to kind of know what's still growing. Lower jaw can still grow for a very long time, especially in boys. In boys, sometimes up to age 22, you can have the lower jaw growing. So keep an eye out for what kind it is. And if you don't know, feel free to take a Ceph. There's services out there where you can take the Ceph, or you can send them to take a Ceph, and they will trace it and digitize it for you and tell you what it is. If you don't know how to read the numbers, you can look it up online or ask me, and I can tell you what it says. This means you have a small lower jaw. This means you have a big lower jaw. This means they're skeletal class 3. This means that the jaw is still growing. So do know the difference so you can be the Miss Cleo for your patient and let them know what to anticipate and when they should start treatment and what type of outcomes are out there. Okay, pseudo class 3. Pseudo class 3s are super duper fun, and I love finding one. They're kind of like finding a gold nugget. Because when you find one, the parents are so upset. Oh no, they have such a big lower jaw, and you're like, really? Gosh, I really don't think it's that big. Do you mind if I just tell the kid? Do you mind if I just like massage your jaw a little bit? I'm gonna give you a little jaw massage. And they're like, sure, give me a jaw massage. And they're like, now I want you to turn the jaw into Jello. And they go. And then you'll just slightly go, and now I'm going to guide your jaw how I want it to close, and you're going to follow along. And you just have them close down, and boom, you get something like this. And if you see this, it's a gold nugget, because their class 3 is not that bad. And you tell mom, great news, might not even need jaw surgery, fantastic, or even that ortho referral, depending on how old they are. Good chance we can just do kind of a retainer and just wear it at night. And gosh, that's gonna fix right up into a regular bite. And they're like, wow, that's so awesome. And then magically, it usually will correct if the patient is compliant. Again, pick your patients. It will correct in 1 to 3 months. And once you correct it, it should retain. Super awesome. So this is your skeletal class 3 again. Okay, so here's our class 3 corrector. Looks pretty much the same as a habit corrector right there, okay? Except for it has a couple little modifications. All right, so we are not trying to encourage the mandible to grow. So that part has been removed, of course. But we are trying to encourage the maxilla to move forward. Now, in ortho, what I used to use a lot with pseudo class 3s, and now, gosh, I know with Healthy Start you don't have to do that. I used to use face masks, which is a headgear that they wear. It looks like a hockey player with rubber bands. Not the nicest thing, not that comfortable. Patients hated it. So, oh, pass it around, girl. Yep, thank you. So, patients don't like it. You tell them, oh, you need a headgear. They're like, what? I don't want a headgear. So you can tell your patient, hey, we can give this a try. You can try this fun little clear retainer. You could just wear it at night and maybe 2 hours during the day. Or you can go to Ortho and have a headgear. Oh, no, I'll try this. No problem, I want this. So, it's cheaper. So, it's gonna go ahead. There is a place where the tongue is gonna go ahead and rest in an area where it's gonna put some pressure on the maxilla. It's not as much pressure as you would with the face mask and the rubber bands, but usually it's enough to jump it. There's also no shield here, okay? So there's no shield here. So different than, I'm gonna pass around the regular adult habit corrector so you can go ahead and compare and contrast. So there's no shield, so the teeth will be able to move forward. If you used a regular adult habit corrector, the teeth can't move forward and you can't jump the bite. So we have areas in the posterior where they can line it or not line it, like we talked about. It can be modified depending on if you have an open bite or a closed bite. And a little place to put the tongue. So pretty neat. So, and you just go ahead and wear it. Usually it self-corrects within a few months. Oopsies. Okay. Okay, so corrected pseudo class 3. Look how amazing this corrects, okay? And to an adult or to a parent, and even to a kid, it's like you're a magician. You had such incredible outcome. And you're gonna change the profile. When you look at the kid from the side, their mandible appears to have just, decreased in size, which the parent loves. They're like, wow, he looks so different, he looks normal. And you're like, gosh, I did that, right? So, and actually you tell the patient, you did that. What a great job you did. If you wait too long to do a pseudo class 3, they will grow themselves a mandible, and now you can't correct it. Now you're talking about jaw surgery. So you need to do this, ideally, I would say before age 8, before age 9, before growth occurs. The longer you wait to do this, and if they're giving you barriers for doing, I gotta go on a trip, I gotta go on a cruise, they're gonna lose it. All right, then I guess we'll refer you to ortho and they'll talk about doing jaw surgery. Oh no, by the way, that's $30,000. No, let's give it a try. So do encourage them to do it as soon as possible. Again, another corrected pseudo class 3. Yes, this patient needs, this is just the first step, correcting this class 3. So because we're not doing the habit corrector. But later we can go ahead and get all these teeth nice and straight. The main thing is that we corrected the bite so that they didn't grow themselves a mandible or affect their TMJs. Look at this little kid here. Look at this malocclusion here. You know that this is not looking right. You know the kid is probably getting teased at school. You know they might have speech problems. They may be getting abnormal wear, cracking their teeth, etc., etc. We want to correct that as soon as possible, okay? It gets worse, it does not get better. This is a little more of the design, but we've already talked about that. All right, so we move from the class 3 corrector just on to our, just like what Jill was talking to our kid or our preteen age series like we did yesterday. Once you finish that, you jump the bite, you move on and finish your Healthy Start treatment. So it's not just about correcting bites, it's also about good aesthetics and improving the occlusion. All right, yay, that was the fun part. Now we'll go super fast into bumpers, okay? So bumpers, like I said, you may never even do a bumper. You may not want to do a bumper. You may hear about this and say, no thanks. No problem. A lot of our doctors, hey John, how many, you're the bumper king. How many doctors are doing bumpers? How many doctors say, I don't want to do bumpers?
I don't know that number, but
yeah.
I would say don't jump into them. Like, get comfortable.
Yeah.
They're not hard. They're just scary.
Jill got data.
I will say, because I get a lot of feedback from doctors that have attended this course that don't want to do bumpers. When they receive a case back that says do a bumper, and they don't, and then they get frustrated because they have a compromised result. So if you don't want to do a bumper, hey, no big deal, but don't treat that case. Because I think it could be frustrating if you don't do the treatment recommendation and then your outcome isn't what you expect. That's not really Healthy Start's fault. You have to create the room. So I would just, nothing is hard once you know how to do it, right? I mean, I don't know if you remember dental school, like a number 4 DO was like, never the first time you do it, right? And then it gets easier and easier. Bumpers are the same thing. So maybe it's not the first thing you tackle, but keep it in mind as you move along. Don't treat a case that needs a bumper without it.
And you can ask for a modification. If they say bumpers, say, is there another way I can do it? Maybe can I do it with IPR? And they can let you know, yeah?
They have I can give you a sheet too, but it's a removable, like a lab made that can distalize as well. So you can do a
Right.
removable thing instead of.
Can we make that?
You'd have to have a lab. Usually they
Yeah.
say.
There's plenty of, that's just the front part of the bumper. So again, you can ask me about that. There's plenty of distalizers. So basically a removable appliance that you're talking about is called a distalizer, okay? They have them at all your Ortho lab, your AOA, your Great Lakes. If you're looking for an alternative, it's not going to be included in the Healthy Start lab fee because what's included is the bumper. Yeah.
No, I'm sorry, I didn't want to interrupt you. I was just thinking about one thing, and there are a couple of videos on how to do the bumpers, so before you just say, take a look and see if it isn't something you could ease yourself into. It's not as intimidating once you watch it a couple times.
And actually, I used to do bumpers all the time as an orthodontist, not necessarily for distalizing, yes. Yeah.
So if we're talking about distalizing, then what are we effectively doing with the airway?
Good question. It's talking about like a millimeter or two. So it's probably not affecting it. It's usually lower, but it can be upper. But yeah, I mean, most of these patients are ones that already had Overjet anyways, and they had asymmetry. So, but where it's not as much as where you're going to collapse the area where you take out buys. Now that's 7 millimeters. For bumpers, we're talking about 2 max, maybe 2.5 millimeters. So shouldn't affect it, but yeah, it's something to keep in mind. So, because you are distalizing all the way back. But bumpers can also be used just to create space. But yeah, if it's yeah, go ahead.
Well, you wouldn't really affect the relationship between the two jaws. You just pushing molders back on the liquid.
Well, I think she is correct because if you actually move all the teeth back, like a lot of people are taking out buys and then you're really collapsing the room for the tongue.
Oh.
So I think she's more talking about that.
So,
but
for like bumpers, it's usually if there's more than 4 millimeters of crowding. So you can do that's just if there's crowding. That's where they deal with using filters.
yeah, I don't think it's enough to really. But I mean, maybe if it was a super duper tiny like coffee straw airway, then maybe it's something to keep in mind. But they're gonna have to get space somehow. So I mean, better to do that I would say than to pull 2 buys. But good question. So bumpers, we'll just go over real quick what a bumper is, how you put it in, super fast. And like Kathy said, there are videos online if you need to do one. And there's some ways that they can help you. Or if you just need the bumper function of distalization and you don't like this idea, you can use your other labs, your Ortho labs, and get your own removable appliances out there. So maybe someday we'll have that. But right now, this is the way it is. So what they're going to do if they tell you you need a bumper is they're going to send you I don't know if we're calling it sheath. I used to call them sheath. It's the labial bow of the bumper. If you're an orthodontist, you're very comfortable with this because we fit headgear all the time. Most people do, or they learn to do it. It fits the exact same way, but they're gonna size it for you. So it's not like you open a drawer and you gotta fit it and find the right size. They're gonna find you the right size and they're gonna bend it for you. So literally all you have to do is plug the darn thing in. Now, you do need molar bands to put it in. So they can actually even give you your molar bands. If you send them a model, they will size the molar bands for you. I would not recommend from a financial perspective to keep a tray of molar bands unless you already are an orthodontist, because that's an investment and it's really few and far between that you're gonna need this. But they can fit the molar bands if you send them an actual model. They will fit it for you, and all you have to do is cement them. Cementing a molar band is no harder than cementing a stainless steel crown. It's super easy. If I can do it and I don't do restorative work, you can do it. So you just you do not want to use a permanent cement to cement these, because if you use a permanent crown cement, you will not get the darn things off at the end. So you want to use somewhere, like I used to use like a Fuji or a Key-Tac or something like that, somewhere in there, either a really junky crown cement or a kind of a little bit better than a temporary cement. So in there's a lot of options. You can see what works for you. So you want something that's easy to remove, but not easy enough that the patient knocks it off. So somewhere in there. And you can ask your orthodontist what they use to. Try a couple things. Main thing is that your bands need to go. You can't put your bands on crooked. You put your bands on crooked, the darn thing not going to go in. You got to put your bands on straight. There's a million YouTube videos about how to cement orthodontic bands. You can do that. And in some states, your assistants can do it. You may have assistants that have done ortho work. Hey, this is for you. Go ahead, take it. Assistants are way better at cementing ortho bands than I am. So because I've done way less than they have. So I can fit them well, but I usually let them do that. Okay. So you make sure, do eyeball it just in case it bent in shipping. You look at it out of one eye. Oh, it looks parallel. Okay, and you put it in. Just pluck it right in like that, okay? Now, the way a bumper should fit is it should be right at the gingival margin, right here, okay? It should not be down impinging the gingiva. It shouldn't be really up where you can see it, okay? So it should be relatively aesthetic. I mean, maybe if they have, especially the lower, you shouldn't see it. And upper, if they have a really high smile line, you might see it. But it's kind of clear. So hopefully not a big deal. It should not be sitting way so far forward that it makes their lip look like it's fat. So you shouldn't have, I mean, they're not gonna love it because it's something in their mouth. And it is semi-permanent. It will be in there for a few months, but it doesn't really hurt. Now the back, see the little bit of extension right there, the distal extension? You need to leave a couple millimeters, and the way they'll size it is to give you a couple millimeters, so as it distalizes, you can still use the same one. So do not trim the back, do not buzz it off, otherwise it's not gonna work. Leave it the way it is, let the patient know if it's bothering them, they can put a blob of wax or something back there. It's not gonna be on there for that long, okay? Do not cinch it back, do not bend it down. Leave it the way it is. Okay. If you want to know about the size, if you somehow think your size isn't right, there'll be a size in there. You can let them know and they can size it up. Sizes will depend on the length of the arch. They'll do it for you. Okay. But there's what the sizes look like. Depends on if they have baby teeth, permanent teeth, extraction cases, etc. Then once you get it in, you're going to take a little piece of power chain. John, do they include the power chain in the kit, or you have to get your own?
We get our own, so I don't know.
I think
They
it comes
can.
with it.
Okay, I'm sure we can ask
They
for
can
it.
they can include every single thing, and they're
Yeah.
not looking to make money on it, so it's pretty much the same.
Yeah,
as your-
I mean, the kid might want their own special color, but you can just use a clear. Clear will turn yellow if you've never seen it before, just letting you know, so don't let them freak out. But the whole point of just getting the power chain around it is just to ligate it around the little hook right here so that the darn thing doesn't fall out. So that's the main thing. And then I think we keep the other side free so they can remove it and brush, right? So that's really nice. Do you guys ever do both sides if they're kids and they're pulling stuff out of their mouth, or you always leave it open?
We've only had to, we've always left it
Oh,
open.
you were in Utah, they're nice. Okay, so maybe where I'm from, you would do both sides in, but all of my bumpers were always fully cemented in. They couldn't remove them, so too bad. You learn to rinse with them around. I mean, compared to what orthodontists do that's fixed in there, this is nothing. So, but yes, Healthy Start, the way they generally recommend it is just ligating one side in so that they can take the other side out and brush and clean around it. That's very, very nice. Okay, it's in there for a few months. Okay, and sometimes there are some crimpable stops where you can activate it. We won't go into all that. It's all on the video if you want to do it. But you can make modifications. But ideally, this is going to go ahead, distalize the back teeth, give you a little more space. It's an alternative to IPR, or it's distalizing teeth, less IPR. So bodily movement in the molars. Unilateral bumper distalization, that's a lot of work. Unilateral bumper distalization. If you only need distalization on one side or more IPR or more movement on one side, you need more space on one side. If it's asymmetric, hey, we're not all symmetric, you can make a modification. You can trim the buccal shield off of this. And then you're only going to get the majority of your distalizations on that side. It's not going to do so much on this side because the lip provides a force and the lip provides the force to distalize. So no worries about that. How does it work? It's going to go ahead and push the little teeth back, and they're all going to kind of go en masse back, which is pretty cool. Things to look out for. Times not to do bumpers. There's about a 6-month period to a 12-month period about the time the kid's about 10 or 11 that you are not going to want to do bumpers. So it's really up to you guys to take a look at the x-rays. Healthy Start is not going to know what's going on unless you sent them a recent x-ray. So this is what time you don't want to do it, right here. Because you're going to jam this darn thing back, it's going to tip, and you're going to impact this. We don't want to do that. So best time to do it is about right now. See, there's like a little bit of space right there. You got a couple millimeters. It's going to distalize, and then this one will just come up right where it should come up. If you're at this point, you're going to probably want to wait till it goes all the way up, okay? But now you got to bumper more. It probably won't move as much because it's pushing against another tooth. So best time to do it is right now, this time right there, okay? But they do say wait till the erupting molar is halfway up the distal terminus before doing bumper use. If there is 1 to 2 millimeter space between the erupting and erupted molar, it's okay to start the bumper without fears of impaction, okay? Always have the excess wire, we talked about that. All right, so here's the way bumpers work. We were talking with John about that yesterday. All your teeth, once they're erupted, they're kind of ligated and tethered together by your PDL and your triseptal fibers and all that kind of stuff. You remember that all from histology. So if you move one, the other ones will start moving too. It's pretty cool. It's like being on a string and pulling them. So as you move this tooth by the force of the lip, this one will start to come back too. This one will start to come back too. It's beautiful, okay? And then the Healthy Start, your G or your IG or whatever, well, it's an adult, so your N or your whatever is gonna go ahead and use the extra space to alleviate the crowding. So pretty fast, you're gonna see that space within 1 month. Neat stuff. Okay, again, review of the bumpers. What does it do? Distalizes the molars, develops the arch, labializes the anteriors, because also if you wearing a bumper, there's less force. All of us have different force in our lips, and the lip is imparting a force on the front teeth. If you have a really, really strong lip, it actually can dip those front teeth back. By alleviating the musculature force on the lips, it's giving space for the teeth to naturally erupt or align with the pressure of the tongue naturally. You don't even have to force it. They're just going straight because you can. Yes?
If you're only ligating the one side with the chain, it's not an asymmetric force. You don't have to worry about having asymmetry.
Actually, we're not pulling the chain. Good question. We're not pulling the chain hard enough to impart a force. It's just on there to keep pulling it out. But I mean, in theory, you could probably use like a long steel ligature guy, to do it too. I mean, I've seen orthodontists do that. But yeah, I mean, if you yanked it, but that's actually not the force. The force is meant to be from the lip. Great question. Yeah, I love it. We should be writing these ones down. Also, we're distalizing the molars, distalizing those molars too, and preventing the molars from, it's providing anchorage, something to pull against, to push against, so the teeth don't drift forward. There's all of our little fancy biomechanical properties of this appliance, which I'm sure you're like, oh God. But yes, there's space for the frenum. Occasionally, if you have a really, really low frenum, you may need to go in there and buzz it and modify it, okay? And if you see it impinging on the gingiva, yes, you may need to get out your acrylic burr and buzz it off. It's all right, it's not a big deal. You can do that. You learned all this stuff in denture stuff anyways, okay? But basically, it's pretty darn cool. And do polish it up if you're gonna do that. The end. Let's go have lunch. Any questions though? Yes, ma'am.
I have a kind of a difficult case, but I had a kid who lost his second deciduous molars early, and so his molars had already drifted forward, and they've turned. So when I started the case, as part of the workup, they sent me a diagnostic review, and it said, you need lip bumpers, and I'm like, great, I want to do it. They sent me the lip bumper with the molar bands, but they were so rotated, I couldn't get the lip bumper in. So we aborted, took the molar bands off. I called to see what they could, is there anything we can do? But
You should talk to me about that. We could have bent
I'm still
them.
willing to try.
Yeah. I mean,
But
I
I
think
tried
the right
bending the
answer,
wire,
they
they
should
were
have
just-
bent them till it went in passively, and then you could have bent them out. You can rotate
But it's
it.
like the tissue is in the way. There's no way.
Oh.
So, I mean, I could send a picture of the model. Maybe it could help.
How long
Yeah.
ago was that?
Just a few months.
We should. That's great feedback for us to give their team because
Because I'm like, I don't know what to do with this.
Yeah.
Like, normally they should just go in, but I want to help this kid.
and yeah, with headgear all the time we rotate molars, but I mean. It's a little difficult to do it remotely. Like, okay, do it. Like, there's a touch and feel. Maybe not your best first case, but darn.
Well, I've done a couple other.
But I'm
bumpers,
impressed.
But that one I was like, I tried
Yeah.
bending it to make it go, and I'm like, yeah, there's no way. Okay, we'll take these off. It's like.
Distalization appliance would be my suggestion for that one. So, and that would have rotated because they'd have like a nighttime coil in there or something, and it would have rotated those teeth. But that's probably what I would have done. But it's additional $100 lab fee, maybe or not. You wouldn't want to do that.
I
But
don't care. I'm willing to try. So I'll talk to you later.
yeah. You can email me later, and I can show you some examples of. Did you do something else with the patient, or are they still kind of hanging out?
So we ended up putting an RPA. He's so restricted, and he's 12. So I'm like, let's just do something quick. So I've got him in a short-term RPE.
Okay.
Hoping to put it back into removable after about 3 months. Just
Awesome.
To kind of get a jump start.
Yeah.
But I still can't do anything about distalizing the molars. So I'm like, I don't know right now. So my mom's really willing to try.
Yeah. Well, retain your RPE for a few months because anytime you do, is it Schwartz or fixed?
It's fixed.
Okay, retain it for a couple months, and then when you take it out, you can always do like a bite plate or something like that, so it's retained even more like you would a retainer, and then we can look into something else. So yeah, show me pictures later. Awesome. Any other questions?